Welcome to the What About Rural Health podcast, a place where research, policy, and real life stories come together to ask the critical question: what about the communities too often left behind? I am Chinasa, a development and global health policy strategist. And for me, this work is personal. From the village health workers struggling with limited supplies to the mothers working miles for care, their stories shape the policies we need. Join me as we uncover challenges, spotlight innovations, and amplify the voices of those at the heart of rural health systems. Because every community matters, and it is time the world listens. Hello and welcome. This is Rethinking Rural Health Financing on What About Rural Health. You are listening to the podcast that asks the question too many people forget. What about rural health? I am your host, Chinasa Imo. Together, we are uncovering the stories, challenges, and innovations shaping healthcare in overlooked communities. In this series, we ask hard questions about how money moves, who gets funding, who gets saved, who gets served, and who gets excluded. From policy to practice, we explore what healthcare financing should look like for everyone. Just for my curiosity, because we can talk all of these things and they could sound so abstract and beautiful, but is there a case study or an example of where community has involved in their health decision-making process that have worked well? So that for my doubting Thomas mind and people who follow me in the back and think, oh, this is not obtainable, that we can share this example that communities who care about their health a lot have actually done A, B, C, D, Z, that then translate decision makers to take them far more seriously than, just woozing in, piloting, doing temporary thing and going away back to their fancy offices.
I think there are several examples in different contexts, right? Currently in Niger State, there's a group of women that call themselves the Crown Women. And what the Crown Women do is that they go around their community and they document under 5 children and their vaccination status.
Wow.
And they have a book where they collect the data. So there's real life data in their community where a group of women have the data of every under 5 in their community, their vaccination status. And based on the gap, they go to the health facility to say, we have this X number of children in our community who are either under vaccinated or are 0 dose. And so what are you doing about it, facility head? That's a great example of how women themselves are driving change in their community. We also saw a situation of the World Health Development Committees in Niger State where, after building their capacity, we saw that the World Health Development Committee could then engage policymakers and also be part of project designs. But I think the challenge was that committee sometimes needed funding to meet. But in the case of the Crown Women that we have in Kebbi, they are funding, they are generating their funds by themselves, and they are doing this. So there are pockets of community, and we're beginning to see in Niger State, in Kebbi rather, these women, through these women's activities, vaccination statuses are beginning to go up, coverages are increasing, because women themselves are now saying our children need to be vaccinated and we don't have to wait for the health system to come to us. We can engage the health system. Now, in the case of the Crown Women, they are not providing funding themselves in terms of money, bringing money to buy vaccines or any of those things, but they are actively engaging the system. They are identifying the problem. They're engaging the decision makers, and they are monitoring to see if those services are then provided to those children. I think so, and I think there are beautiful case studies across the globe. But what we need to do is how this can become routine.
Absolutely true. And for my listeners who will be listening to this episode from different parts of the world, the places that we've been mentioning, Kebbi State, Niger State, Abuja, all of those are in Nigeria. Those are places we've used to cite examples of our case studies. So we'll take a quick break. Do you want to drive rural health forward? We are looking for passionate volunteers to support our work, from research to storytelling to outreach. If you believe every community deserves care, join us. Visit the link in our bio or show notes to sign up. Welcome back. So, Tariah, we have been talking a lot about health system, and I know that beyond Nigeria, you've also worked in other parts of Africa, both in emergent and non-emergent health systems. And you have led measurable outcomes. I give that to you. What made those interventions work? Is it like community trust? I'm just speculating here. Is it local ownership? Is it smart incentive, cost efficiency, or accountability mechanism, or other things that I may not even think of? Take your time to provide. And it could be none of these things, but I just want to crawl in your headspace and see what and see what makes your work really impactful.
Thank you. Yes, I have worked in Zimbabwe. I've worked in Malawi, supporting governments and supporting partners to respond to polio resurgence in Malawi. And in emergency response, one of the things that is clear is there's an there's an urgency around how we want to solve problems. And one of the things that have worked, firstly, is political will.
Yeah.
In Malawi, I saw how the government itself was invested in how the response was being implemented and activated at every level. And the Minister of Health was accessible, was interested, was actively involved. So I feel like in my work, it's that the political leaders, the policymakers have to also have interests. They have to lend their voices, because their voices give credibility to the work. I saw that really, really play out in Malawi. And that taught me an important lesson that sometimes, yes, the experts in quotes might not always be the best messengers. It's about the people that the communities trust. Another thing I saw really work out was community trust. And especially when you're dealing with vaccines in the wake of COVID and the infodemic in the system, community trust becomes the operating system of service delivery.
That is true.
Once you meet community trust, then all your services are questionable. And how does that play out? It's community engagement.
Yeah.
And it's actually just sitting down and talking to the communities. And when I mean talking to the communities, listening to what their concerns are. Because you have to listen to even understand what the concerns are, and then design programs that respond to those to those issues. And so one of the things that worked very well was community trust, and basically using trusted community actors to have conversations within their communities. Is also being predictable. I think it's also being predictable in the sense that when we say we'll show up, we show up.
Yeah.
That also plays a really big role. And also being aware. I know we say it a lot, but that communication is a two-way street.
Yeah.
So we're not just coming with information to you we're also able to admit when our information is not right.
Mm-hmm.
We're also able to incorporate what you're saying into how we're communicating. And that goes back to the kind of health system that's operating in the place. And I think so. So part of that, I think another thing that really worked well was local ownership. Local ownership drove co-designing. For example, designing of microplans. You don't know a community more than a community on people themselves. So putting decision makers closer to the delivery, inviting decision makers to not so we do this thing sometimes in health where we go to rural communities and then we have those conversations. And when we come to the very high level meetings, their voices, we go and represent them. But I think one of the things that we did in Malawi so well was also bringing community into those high level,
Wow,
bringing community into those high level meetings to speak for themselves.
that is beautiful.
And those are some of the things that that works very well in how we implement how I've designed communication strategies and how that design has translated to change. As a communication specialist, I think one of the most important things that you will learn is context is everything.
Yeah.
There's no one size fits all. And so your ability to listen, your ability to adapt, your ability to understand the system is what works, and responding to the system and the people is what drives effective implementation. And of course, partnership coordination. I supported the partnership coordination, leading the GPI partners and coordinating them. One of the things that worked very well was also partners showing up as one. So if you saw UNICEF in a community, they were saying the same thing that WHO will say. Messaging was so aligned that it spoke to the response and not organizations or ideals or views, individual views. Every organization that worked, messaging was very aligned and ingrained in a way that the center of that conversation was always the people and the response. And when we have fragmented conversations with different partners, not focusing on the issue but looking for identity is one of the things that creates chaos. And I think partnership coordination played a really huge role, beyond all the other things that I've mentioned, in how response was delivered, how response was implemented, how program designs were done. Yeah.
Wow. I must commend you for all of your good work and all that you've explained here. In fact, that is what we have been advocating for. And while you were mentioning that, if you would look over here, my audience will not see, but you will see this picture of me standing with Medicine Sans Frontieres staff. This person is from Ministry of Social Welfare, and then the other person is Ministry of Health in Sierra Leone. Typically an example of what it means to carry community along, to allow communities to lead on the intervention that we anticipate. So, backstory to this is during the Ebola outbreak in Sierra Leone, I was part of the response and I was a pillar head for psychosocial support and risk communications for the African Union. And even though I was kind of like supervising around other kind of districts, however, I was working directly in Tonkolili district. And we got a case of a community, I think it's called Moyamba. And this community had refused intervention. Medicine Sans Frontieres have been there a couple of times. They keep telling them we don't have Ebola cases. Meanwhile, people were dying in the community. However, this same community will be calling the Ministry of Social Welfare to say, our children are dying. They are actually dying of hunger. So it was nutritional issue. In fact, I wrote a beautiful op-ed blog that is published on African Union website of the intervention that we did. And so fortunately, I was with this person coordinating this thing, and in his office we were strategizing on how to gain local ownership, how to move social mobilization down to the community and allow community to also communicate to us what the needs, their needs, and how we can support them with all of the resources on ground that are made available to me as the pillar head. And this call came in and I just stood up and said, let's go. They said, this Nigeria woman, you want to follow me to Moyamba? I said, yes, let's go. He's speaking in Kroya. I said, let's go. But you don't hear the language. How will you do that? I said, let's go. When I got there, we got there, with my red with my red truck that everybody knew me with in Sierra Leone. I begin to ask question respectfully. Who is the community chief? Take me to the community chief. They took me to the community chief. I stood there. I do have other pictures on my Facebook where I was engaging with the community. We discussed. The chief says, I am trusting you because of the way you approached us. Other people come with red ambulance and they begin to open our doors to pick out people affected by Ebola. You come with a red car, but it is not an ambulance, which means you are not bringing death to the community.
That's powerful.
This is our problem. Our children are dying because we are not going to the farm, so they don't have food. I say, hold on, sir. I pick a phone call and I call the ICC manager and say, do you have space? I do have. I say, I come back to him and say, how many kids do you have severe concern for right now? He said 20. I say, my car will not fit 20. Is it okay that I order for them to bring a blue ambulance? He said, yes. I asked them to come with a blue ambulance to get the kids. I brought out my record and I took the names one after the other. It was painstaking because I don't know how to spell, but I made sure that I document. I said 20 children are leaving this community for help. 20 children are going to come back. However, when these people are coming, we would do rapid testing so that we will know how to put them. For those who are not affected, those who are affected, we'll all take them and treat them and bring them back. He said, okay, how many days? I said, you will hear from me in 3 days' time and in 7 days' time and in 14 days' time. By that time, we had rehabilitated those kids who were malnourished and brought them to the community. We came with food because we went WFP. I was working with them. They give us a lot of food. We came back with food. We came back with healthy kids. They themselves were opening the doors and bringing out the sick EVD people and say, take them. I now asked, do we now have the permission to bring the red ambulance? He said, yes, only if you guarantee that if they die, if anybody die, we know the reality. We hear story. If anybody die, please update us because the ones that have been taken earlier on, we don't know their status till now. So if they are alive, return them back to us. So community just need that trust. But they also need us to be part of that participation.
Thank you for sharing that really wonderful story. I really was just smiling through the story. But I think one thing that you've pointed out in that story is feedback loop.
Yes.
And that's really important in healthcare service delivery in terms of when you come and engage community, how do you come back to provide feedback?
Exactly.
I think in some cases there are no engagements. In some cases there is engagement. But you find very few cases where there is then that feedback to the community to say, this is what we have done.
Yes.
With the information that you've provided to us. And that gets back to how lack of trust in the system is created and that lack of trust can be impacted. So yes, as we begin to design programs, as we continue to work, it's important that we take this lesson of feedback and how important feedback is not just an activity, it is an enabler of how services are delivered and what we must consciously institute in our plans as well.
Thank you. And I want to just shift a little bit to ask you. Now, all of these lessons from emergency response, how can we apply them to long-term rural health financing? Because there's a lesson in health emergency that is not yet translating to systematic and systemic service delivery.
I think a few things are important to learn from emergencies, and I must say that the African system, African health system, is continually responding to emergency, and so we must see emergency not just as emergency in a system where we're always responding to emergencies, but how it's a continuation, how it's a part of the health system itself, and not something different from our health system, and translates the experiences and knowledge into everyday practice. I think one thing that is really big during emergencies, like is speed, flexibility. During emergencies, there's a speed and flexibility that every person has that is not then translated when we are out of emergency. And I think in emergency, even funding is more flexible, and people will move budget lines because there's a problem. There's rapid programming. There's simplified approvals. Bureaucracy sometimes stands still when there's emergency. Funding for logistics, supervision, transport. These approvals happen very quickly during emergencies. Long-term rural financing can borrow by, just taking these things. How are we flexible during routine services?
Yeah.
How is bureaucracy, in terms of long approvals, becoming a barrier to how health services are being delivered? I think that's some of the lessons. Another thing is a clear command and control system that we have during emergency. Emergency response, there's really clarified roles.
Yeah.
But when you come to routine services, sometimes the lines are blurred.
Yeah.
And you hear people saying, "Oh, this is not my role. This is not that." But during emergency, there's that clarity that everybody has as to what they need to do. And I think that that's what we need to do. Also, program performance. During emergencies, program performance is something that is done so nicely
And
rapidly. But that does not happen during routine. I think another thing is community mobilization.
Yeah.
Community mobilization becomes a backbone during emergencies. Communities are involved, communities are engaged. But in routine healthcare service delivery, it's not the same. And I feel like these are things that also tools. During emergency, there's so much tools, resources, even technology. In their dashboards are developed and reviewed daily. There are several tools that are deployed. How are we not then utilizing
Translating, even if it's translating those to routine
activities? So it's a bad practice that a lot of times. Also, capacities of people that really rapidly built during emergency. But when we get to routine, when we get to the day-to-day delivery of rural healthcare service, we don't take those lessons.
anything can apply.
And those are really, especially resources and tools. Those are things that we can actually incorporate into routine services and not just emergency. And I'm actually often shocked how these things are not translated, because the same health worker is working during emergency, but somehow has just a different approach when it comes to routine service delivery. And that's because the system is not, it's responding to emergency like it's this is an emergency. I get the need for a marketable. How do we then look back during every response and then take this and translate into our services? I think that's really, really important.
Beautifully said. I agree with you. But I wanted to ask you this one last question as we begin to wrap up. I mean, it's not my last question, but it's second to the last question. Like, if we are serious about sustainability for rural health, what would, a rural health fund financing model, what do they need to do differently? Is it prioritize community-led priority settings, or having the one you mentioned before, I think you said blended funding, where you have both public, private, and community, all contributing to the purpose of making sure that, health systems is well funded? Or do we still look at piloting culture, or do we pivot a little bit more to long-term investment, or do we need to think about and apply those based on the scenarios? Just what is it if we want this sustainability? I'm looking for that response.
I think it's a combination of many things. One, you'll need community prioritizing,
Okay.
because if health must be delivered to the needs of the people must first design the health system, must first, not like the system, but the programs that reach the people. So there's community prioritizing. But I think the conversation of blended financing is a conversation that we must begin to
That
have.
needs to happen yesterday.
That needs to happen yesterday. And more importantly, in the face of dwindling global financing. We all saw in 2025 what happened with USAID funding.
Mm.
And we all know the impacts of what the absence of that fund has on communities and people.
Yeah.
Beyond that, what does it really say? It means that external funding alone is not sustainable.
Yeah.
And so we must begin to have conversations, and also government funding, because in governance itself, everything seems to be a priority, whether you go to education, whether you go to healthcare. And so we must be more realistic and accept that external funding alone, government funding alone, cannot solve the problem. A sustainable financing model would include every stakeholder of interest in that space.
Yeah.
So that systems can be upheld, so that no one is left behind. Social enterprise is also something that can be explored. So yeah, I will go for a blending financing system, and then those conversations can be had to then look at what that, like I said, healthcare is about context, about what works, how that plays out in a system, in a community. But blended financing is an option that we have to look at in the face of dwindling global finances, scarce national resources. That conversation needs to be heard, and needs to be had like yesterday. And we need to then come up with models that fit each context and what that will look like.
Thank you so much. I just let me try and see if I can recap all that you have said. What I'm taking away from this conversation is that sustainable rural health funding cannot be something that only happens to community. It has to be driven by them. Communities understand their needs, they know the gaps and their priorities far better than any external actor or any external funder. And they should be able to center decisions on how health resources are raised, how they are located, how they are sustained. And when communities are empowered to do this and shape health funding mechanism, they build locally rooted systems that will serve them. But they would also have the ability, because they know all of these things, they would also have the ability to hold institutions accountable. Like if government say, I will water you and fire you, and you check after 6 months, they have not done that. You should be able to galvanize as a community and begin to hold your stakeholders, starting from the person representing you at local level, ward level, local government level, state level, before we get to where we talk about national level. Hold these people accountable. And what that means also is that it gives real agency over who receives care. And communities need to start deciding what healthcare delivery will look like for them in their own terms. I hope I am able to recap all of that.
Yeah, I think you did a great job.
Thank you
I
so
think you
much.
did a great job of that.
So as we wrap up, Tariah, I usually like to end on a good note. And I want to ask, what is that one thing that you would wish community, policymakers, funders, institutions need to unlearn about rural health funding so that we can move to this sustainability that we've been talking about?
Oh, thank you for that question. I think it's a number of things, right? That health systems policymakers need to unlearn. I think one is that national indicators are able to capture what health outcomes mean at rural level.
Yeah.
Two, it is that women and volunteers can endlessly and freely fill the gap of skilled work without the payment that is required.
We need to unlearn that quick.
I think that we need to really unlearn conversations about how volunteers are able to fill that without being paid. We can't shift. I get the entire concept, but to design programs or to hope that a burden will be carried by communities that simply just volunteer endlessly and women, I think it's not something that is sustainable. And I also need to, I think we also need to unlearn the concept of community participation in terms of just inviting people into these meetings. Yeah. We need to start embracing what listening to communities really mean.
Yeah.
When we actually, because the first rule of problem solving is identifying the problem.
Yeah, that's true.
So unlearning program design strategies that do not put the voices of the communities into consideration. It's something that we must all unlearn. So yeah.
Thank you. Thank you very much for joining me in the studio today. I would say that rural health does not need more short-term fixes. It needs sustained commitment, trust in communities, and funding models that match the realities on ground. So, to everyone listening, thank you for joining us on today's episode of What About Rural Health? If today's episode moved you, challenged you, or made you think a little differently, please follow, subscribe, and leave us a review on our favorite podcast platform. And as always, let us keep asking the question, what about rural health? Until next time, I am still your host, Chinasa Imo. Bye for now.